Thank you, Senator Daines. So we were talking earlier about drug companies, but they're not the only ones who have figured out how to game the rules and drive up costs. A few decades ago, Congress started letting private insurance companies administer Medicare for seniors who opted in. The insurance companies claimed, when they first were getting permission to do this, that they would run Medicare better than the federal government. More benefits at less cost. That was the promise. But over the past 12 years, Medicare Advantage, the part of Medicare where insurance companies have the biggest role, has actually cost the federal government $143 billion more than traditional Medicare. Meanwhile, insurance companies have soaked up literally billions and billions of dollars in profits from undertaking this. Now, one serious problem is how Medicare pays insurance companies. So let's imagine a specific patient who goes to the doctor for her heartburn. It turns out that this patient had shoulder surgery a few years ago. She also has exercise-induced asthma. Dr. Chernew, would the patient's surgical history or her asthma diagnosis affect how her doctor gets paid for this visit in traditional Medicare, if she's covered by traditional Medicare? Dr. Chernew?
I'm here.
There you go. Go ahead.
Sorry. No, in fee-for-service, physicians get paid for the visit and related tests and services that they provide, which in this case would likely be limited to the patient's heartburn or whatever condition they went in for, not a bunch of conditions that happened in the past. It's not what they're being treated for at the time of the visit.
Okay, so let's keep building on this. So in traditional Medicare, doctors are paid for the services they provide. And for this patient, if her doctor doesn't need to take an x-ray of her shoulder or prescribe her a new inhaler for her asthma, then those diagnoses may not even appear on her record. That could mean that doctors in traditional Medicare underreport diagnoses, but Medicare Advantage has the opposite problem. Dr. Chernew, how would discovering those additional two diagnoses change the way that Medicare pays Medicare Advantage for patient care?
Sure. So because Medicare Advantage gets paid more for patients that have more diagnoses, at least in the following year, they get paid more. They would generally get paid more if they're able to record more diagnoses. If I could, let me illustrate with a slightly different example, which is some work that a colleague of mine, Tom McGuire, did suggest that for every 100 patients in fee-for-service with congestive heart failure, only about 75% have recorded congestive heart failure in the following year. Because Medicare Advantage plans have the financial incentives, they devote resources to identifying those patients. And by adding that code, the plans therefore get paid more for identifying undiagnosed congestive heart failure or preventing previously diagnosed congestive heart failure dropping off in subsequent years. And that leads to higher Medicare Advantage payments because the risk adjustment system, as you point out, is poorly calibrated.
Okay, so this risk adjustment means that payments are going to go up. And I get the underlying logic that a sicker person is going to use more healthcare services, so Medicare is going to compensate for the additional risk. But I take it that what you're saying, Dr. Chernew, is that having a higher risk score in Medicare Advantage does not necessarily mean that the patient is either going to get more care or better care. Is that what you're saying here?
Yeah. Well, they might not necessarily get more or better care, or they might. It's the calibration issue. But yes, you're correct. They might not, those added codes may not actually be treated. That is true.
Okay. And Medicare Advantage plans, they're not finding new diagnoses so they can help people get more care. They're doing it so they make more money for Medicare because that's how the system is set up. In fact, an entire industry has been created to help them do exactly that. And as a result, Medicare ends up paying more for a beneficiary's care in Medicare Advantage than it would pay for exactly that same beneficiary's care in traditional Medicare. So, Dr. Chernew, you've studied this for a long time. If the federal government cracked down on these insurance company practices, how much money would it save Medicare?
So the Medicare program already takes some money out to adjust for this miscalibration. The commission believes that that's insufficient. And so if you took out another 3 to 4 percentage points, for example, which is our estimate of the added payment, in 2021, you would have saved about $10 billion.
Wow. Yeah, that's, and you know, I actually, we were looking into this, my team and I. It turns out that other experts have even put the number higher. Some say as high as $600 billion over the next 8 years. Think about it. That one change alone creates more money than the hospital insurance trust fund's entire projected shortfall through 2031. And that's not even the only scam that Medicare Advantage plans use. We could save almost $200 billion more by eliminating some of the other tricks that Medicare Advantage plans use to squeeze money out of Medicare. That would be enough to make a down payment on lowering the Medicare eligibility age or adding dental benefits to Medicare. Insurance companies have promised more competition and lower costs for decades, but instead they have cost the Medicare program billions of dollars. And that's because the goal of giant insurance companies is not to save the government money. The goal is for the insurance company to make profits for themselves. And more often than not, they do that by ripping off the federal government and denying people the care that they need. I think it's time for Congress to put an end to this kind of corporate profiteering. So ordinarily at this point, I would hand the questions back over to Senator Cassidy, but we're trying to manage votes at the same time. So Senator Cassidy's not here. So I'm going to turn around and go to another round of questions. I'm not going to let you all waste any time at all. So here's where I'd like to start on this one, and that is in 2019, the Trump administration announced a new Center for Medicare and Medicaid Innovation, CMMI, initiative to allow private plans to use the same scams that they perfected over in Medicare Advantage over and import those into traditional Medicare. Once again, driving up costs for taxpayers. Now, under CMMI's direct contracting model, Medicare beneficiaries will be assigned to a direct contracting entity. We heard about this earlier in direct testimony here. These are called DCEs. And like the insurance companies in Medicare Advantage, DCEs will receive a fixed payment to cover the beneficiary's care. But then they get to pocket virtually all of the money that they don't spend on patient care. This has set off a global gold rush on Wall Street. So beneficiaries are enrolled in DCEs based on their primary care provider, so that insurance companies, private equity firms, and institutional investors are scooping up primary care practices so that they can get in on the deal. And these investor-owned doctor practices use the same playbook as Medicare Advantage to squeeze more money out of Medicare. Dr. Rogers, you spoke about this, you have studied this. Of the 53 direct contracting entities that CMMI has already approved, how many are owned by private investors and insurance companies as opposed to hospitals, doctors, and other healthcare providers?
Thank you, Senator Warren, for this question. There are 28 DCEs, and out of that, there are 28 DCEs that are investor-owned, and there are 6 that are owned by 4 Medicare Advantage insurers. So these are the ones that are there for the profit. And to me, there's clearly a conflict of interest if you are there to provide health care, but your mission is to make money. It's a conflict of interest, and it's not going to ever be equal. And unfortunately, who is going to lose are patients. Denial of care is the way they will control costs. They will limit access, pre-authorization. There's a lot of mechanisms that are there. One of the things that have been done too, and we talked about the upcoding and how, patients are made to look sicker. It's embedded in the software. So as a physician, I can't sign off on a chart until I've clicked enough boxes so that they can upcode. So
Wow.
it's part of the infrastructure now, so that it's not what I want to diagnose them as their provider or their physician. It's embedded there in the structure.
And this is by design. I mean, what you're talking about when you say it's embedded in the structure, the majority of these DCEs are investor-owned, and CMS has said that one of its goals for the direct contracting model is to bring in organizations, and I'm going to quote them here, that currently operate exclusively in the Medicare Advantage program, to bring that into traditional Medicare, and to make the deal even more attractive for these private actors. CMMI has weakened key guardrails that will allow insurers and investors to pocket even more profits through the direct contracting model than they can now do in Medicare Advantage. So let me ask another question around this. Under Medicare Advantage, plans are legally required to spend at least 85% of their revenues on patient care. Essentially, sets a 15% cap on total profits. So, Dr. Rogers, does the same cap exist in DCE programs?
Well, it's a very much smaller cap, I can tell you that, because the DCEs only have to they can keep up to 60%. So
that's right. So, in other words, they can make 40% in profits.
They need to spend 60%. I had that backwards.
Yeah.
They need to spend 60%, but they are able to keep 40%. So when we talk about trying to control costs, they're not adding anything to care. These are investors. They know nothing about healthcare delivery. These are investors who are making money. And to me, I think healthcare should be off the buffet table when investors come in and decide what they want to put on their plate.
But,
There's no room for them.
I want to say on this, I support coordinated care, and I appreciate the potential that coordinated care models have to lower costs and improve the quality of care. But give me a break on what's happening here. Wall Street is not racing to buy up clinics because they want to expand coordinated care models and limit profits. Private equity and insurance companies want the eye-popping profits that are possible when the federal government lets them pocket whatever it is they can avoid spending on seniors and people with disabilities who need health care. So, Dr. Rogers, right now, as you know, we are in a demonstration project phase on this. If this demonstration project is allowed to proceed, does it effectively amount to a privatization of Medicare?
Totally. If you look at our healthcare system now, Medicaid is very much privatized, private insurance is privatized. There's several other things. And then the other big one is Medicare, which is becoming privatized. And by privatized, I mean public monies are going into an entity and giving total control of that entity to those dollars.
Yeah.
That is complete privatization.
So privatization, and let me just ask, over the 35-year history of Medicare managed care, including Medicare Advantage, have these private sector arrangements ever delivered the cost savings that taxpayers were promised when the plan started?
Never. They paid billions, and in fact, there's managed care companies have paid hundreds of billions more than if people had been in traditional Medicare. Remember, traditional Medicare has an overhead of 2%. There's nobody working in DC and in CMS who's making millions of dollars a year as their salary. So you've got a whole, different system in the private system, and that's where all the money is going. And even if we look 8 years ahead, because the DCE from CMMI, they want to move everybody into they want everybody to move from traditional Medicare to these DCEs by 2030. And that will cost us more than $600 billion.
Yeah.
So this is not about providing care. I mean, this is, it's all about making money.
Yeah, thank you, Dr. Rogers. It is completely baffling to me that the Biden administration wants to give the same bad actors in Medicare Advantage free rein in traditional Medicare. Without intervention, the 53 existing DCEs will enroll as many as 30 million of the 36 million beneficiaries who are now in traditional Medicare. That means that 80% of traditional Medicare will be privatized. And the new owners of Medicare will use the same scams they've been using for years in Medicare Advantage to drive up costs of traditional Medicare. My view is that President Biden should not permit Medicare to be handed over to corporate profiteers. Doing so is going to increase costs and put more strain on the hospital insurance trust fund. The Biden administration should shut down the direct contracting model immediately. And I see that Senator Cassidy is back, and Senator Cassidy is recognized.
Dr. Kapczynski,